Good afternoon, and thank you so much for inviting me. Research Days has been really awesome. I'm going to talk today about the art of asking questions because I feel that it is the foundation of public health. These are my disclosures. And I'm going to just start by saying in my career, I have had really great fortune to work on landmark initiatives, and I'd like to share stories about a few. So it all started for me when Rosalind Carter asked her husband, the 39th president, how many people have been treated for mental illness? He didn't know, so he asked the people who then were the beginnings of the National Institute of Mental Health, how many people have been treated for mental illness? But they didn't know because they said, Mr. President, we don't even know how many people have mental illness. So Jimmy Carter commissioned the National Household Survey to assess psychiatric disorders in the community. 5 sites applied and were chosen. One was in St. Louis, my hometown. I was at Boston University at the time, and my professor told me about the study. I applied, and I was hired to be the coordinator. Well, for the study, we needed a structured interview for non-clinicians to assess mental health. And this study was called the Epidemiological Catchment Area Study. So this is how I learned the art of writing and asking questions. And it was to detect symptoms of mental illness. So at the time, we began developing the diagnostic interview schedule. And then a little bit later, we did the substance abuse module to go along with it. And these interviews were operationalizing the DSM-3 criteria, but they've been updated over the years for DSM-3R, DSM-4, DSM-5, even the ICD-10 and 11. And so with the study, for the first time, we had data on prevalence, natural history, and comorbidity of psychiatric disorders. We learned that developing the concepts takes time and empirical evidence, and that operationalizing the concepts to empirical indicators takes skill, and that even trivial issues we had to standardize, like what is some, what is a few, what is many, what is repeatedly, what's persistent, and that, of course, the assessment needs serious beta testing. Well, with the art and dominance of AI, writing questions and asking questions is more important than ever. We learned that an effective diagnostic interview provides an accurate operationalization of multiple diagnostic systems, DSM-3 and ICD. It should be specific to capture the absence of illness as well as illness, highly structured, easily understood, reliable when it's not dependent on the medical record or a proxy, because internalizing symptoms are not always shared. And it's best when it's not more than a couple of hours long. And we also learned that the psychometric properties of the assessments were critical. Over the years, I've been funded to conduct reliability and validity studies of our assessments from a test-retest format. Different studies for different drugs, different nomenclature, with one enhancement. For the first time, we sought to understand why a diagnostic criterion or the way we operationalized asking about it might not be reliable. So we asked people why they might have given 2 different responses, and we offered the participant an opportunity to resolve the discordant answers. And we called it the discrepancy interview protocol, a method for evaluating and interpreting discordant survey responses. These surveys have had an impact. These assessments were the original diagnostic assessments upon which others would be built for making psychiatric diagnoses. And these predated the SCID, the SADS, the CD-Audatus, the MINI, the SCAN, the DISC, and the Toolbox assessments. They have been internationally used, and they have helped to further clarify and even improve diagnostic criteria for a unified concept of disorders. Well, these have all led to additional studies and assessments. For example, with the NFL, we did a study with 650 former NFL players for injury, pain, and prescription opioid use among these former players. And we found that the prevalence of opioid use was about 7%, which is 3 times the rate in the general population. This was the first study of prescription pain pill use among former NFL players. This paper was submitted right before the Super Bowl in 2011, and it's had an impact on practices of the NFL and made some headway into reducing pain pill use. In fact, this was tested for a certificate of confidentiality twice. Here at the University of Florida, people came to my office, they handed me subpoenas, they wanted the data. But because of the certificate of confidentiality, we could not give it. And then also, Hillary Clinton, she wanted to know what was the effect of opioid smoking on youth in Afghanistan. So we did a study funded by the U.S. Department of State on the prevalence of drug and alcohol use in urban Afghanistan. This was the first study of its kind to compare self-report of substances with 3 biological tests, hair, saliva, and urine. And you can see here that 11% of the households had 1 or more people testing positive. And you can see the rates here for men, women, and children. Also, it was the first time that the female head of the household was the respondent for the people in the household. And we learned the prevalence of heroin and opioid use, 6.8% lifetime, 1.7 in the past 30 days. We've also been asked to inform preclinical research on how humans use drugs and in what sequence. So for a back translational model of cocaine and alcohol use, cocaine and marijuana use, opioids and alcohol use, and all 3 at once. So we were asked to develop a new interview to go along with the substance abuse module. And it has been the first study of its kind, going from humans back translating to rodents. Now on the left, you can just see the format of this assessment. We're asking people about their use of drugs in the past 30 days. And then on a typical day, we're asking them how they use it, frequency, and the pattern, the sequence, and the quantity of their use, so that we can look at the frequencies, all of these, with the sequencing of these drugs. And then hand that over to the rodent modelers, who then give that drug to the rodents. These skills have all led to the harmonization of these epidemiological concepts through our NIDA-funded National Drug Early Warning System. We are the coordinating center here at the University of Florida, and we have 3 different ways of monitoring and surveying emerging drugs, and I'm going to talk about a few of those today. So we also have an early warning network, and we also disseminate this information multiple ways, including our weekly briefing at 9 o'clock on Friday mornings. Our Rapid Street Reporting interviewer team is made up of 2 UF students, doctoral students, master's level students, and they're paired with staff or students from our Sentinel sites, which is shown on the map here, 17 different sites. We also have hotspots around the country. They go out on the weekends and they interview people about their use of substances. This is a picture of 3 of our students having fun collecting data. Our rapid survey assesses for the use of common substances, shown here, as well as other novel psychoactive substances. Now, this is a 10-minute anonymous survey, and for that, we give a $2 bill. We ask for their saliva, and we also offer another $2 bill. We've had over 40 visits, and our database has over 9,000 people to date. 45% of the sample has been recruited from the sidewalk, 25% from shopping areas, 30% from different events, sporting, music, outside of nightclubs, etc. Wherever we go, the top most commonly reported drugs in the past 12 months are very similar, but they're mostly identical for this top 3. Marijuana for recreational use in about 50%, psilocybin or shrooms in about 14%, and marijuana for medical use in about 13%. We disseminate this information weekly in a format like this. On the left, you see the city. This one happens to be St. Louis. You can see the drugs that have been used in the past 12 months and 30 days. And on the right, you see the characteristics of the participants. We also have the web monitoring of new psychoactive substance trends in drug subreddits. And this is conducted by our colleagues at Florida Atlantic University from their Perception and Cognitive Lab. They have about 80 drug subreddits. They're looking at Reddits for drugs or classes of drugs, general topics related to drug use or experimentation. And we detect trends. Early on when we were doing this, we were looking at 8 different novel psychoactive substances, and you can see here in this publication, we had 7 of the 8 evaluated were mentioned on Reddit before they emerged in medical examiner or coroner reports. So Reddit is a great predictor of increased related exposures. This is an example of the format of our web monitoring reports on our Friday briefing. And this one is about fentanyl. And you can see there's a decrease over time, which everyone is seeing around the country. We explain why we're using this drug for this report. What is it? What are the public health impacts? And what is the public sentiment about it? We also talk about the search terms as well so that it could be replicated. The other one surveillance method that we use is our 911 encounter data from Biospatial. This is where we look at emergency medical services data that are accessed through the NEMSIS program. 75% of this data comes to us in 24 hours. We have over 100 million records in the database. And these are some of the reports that we give. So starting on the left, you can see a heat map showing where the overdoses are occurring at the time of the day or the day of the week, moving across to the states and the counties where the overdoses are most prevalent. And then we see trend analyses as well as characteristics. Please subscribe to our free briefing by clicking on this QR code or going to ndues.org and go to the red tab at the right-hand side at the top. You can subscribe for free. If you're interested in working with us, we'd love to have you. If you want to go on any trips with us, we'd love to have you. If you want to do any data analyses, we have data for you. So in closing, I just want to say, assuring the quality of questionnaire data and epidemiological research has been at the forefront of our minds since 1970s. This is a paper by Leon Gordis, and he said, no scientific discipline can be any better than the quality of the raw data. So asking the right questions is really important. So welcome to the future, where primary data collection is going to be more important than ever before. Asking questions has gotten me where I've been, where I am, and where I'm going. It has been really the single most important thing that we can do in our field as well as epidemiologists. And it's brought me to many different places around the world, working with many collaborators who are also involved and interested in doing the same thing. I'd like to acknowledge my mentor, my funders, students, colleagues, administrators, and staff and family, with special thanks to Zoe Martisevich for nominating me for this Pillar Talk. Thanks, and have a great rest of the research days.